Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 1 Bundle podcast, which gets you all of Crush Step 1 and our Step 1 Question podcast combined and ad-free. You'll also get early access to new content as it becomes available. Upgrade your studying now and learn more at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 1 Questions podcast. And in this episode, I'll be reading 3 more pathology questions from our online qbank, and as always, you can read these questions and more at medprep2go.com. So with that being said, let's get started with question 1, Pathology 55. A 19-year-old woman presents to the emergency department with a 16-hour history of abdominal pain, nausea, and low-grade fever. She states the pain began around the umbilicus and later migrated to the lower right side of her abdomen. She has vomited once and reports anorexia. She has no significant medical history and takes no medications. Vital signs are temperature of 38.2 degrees Celsius or 100.8 degrees Fahrenheit, blood pressure 114/72, pulse 100 beats per minute, and respirations 18 per minute. On physical examination, the abdomen is soft but tender in the right lower quadrant with guarding and rebound. Passive extension of the right hip elicits pain. Bowel sounds are present and normal. Laboratory studies reveal a leukocyte count of 13,800 with 85% neutrophils. Your analysis is normal. Which of the following is the most likely diagnosis? Is it A, acute appendicitis, B, Crohn's disease, C, ectopic pregnancy, D, mesenteric adenitis, or E, nephrolithiasis? And the correct answer here is A, acute appendicitis. Acute appendicitis is the most common surgical emergency in young adults presenting with right lower quadrant, RLQ, pain. This patient exhibits the classic progression of symptoms: vague periumbilical pain, visceral innervation, that migrates to localized RLQ pain, parietal peritoneal irritation, accompanied by anorexia, nausea, low-grade fever, and leukocytosis. The presence of peritoneal signs such as rebound and guarding, and a positive psoas sign, meaning pain with hip extension, indicating retrocecal irritation, further supports the diagnosis. Appendicitis is a clinical diagnosis often confirmed with imaging such as CT in equivocal cases, though treatment should not be delayed in patients with classic findings. Answer choice B, Crohn's disease, is incorrect. Crohn's disease can affect any part of the GI tract, but commonly involves the terminal ileum, presenting with RLQ pain, diarrhea, weight loss, and often a more indolent course. Acute onset with migratory pain and marked localized tenderness is less typical. Fever and leukocytosis can occur in Crohn flares, but the absence of diarrhea, chronic symptoms, or prior history makes this diagnosis less likely here. Answer choice C, ectopic pregnancy, is incorrect. Ectopic pregnancy often presents with lower abdominal pain, possibly localized to one side, and may be associated with vaginal bleeding, hypotension, or signs of rupture. Although it must be ruled out in any woman of reproductive age with abdominal pain, this patient's presentation is most consistent with appendicitis. A urine beta HCG would be essential to evaluate ectopic pregnancy as a possible etiology. Answer choice D, mesenteric adenitis, is incorrect. Mesenteric adenitis can mimic appendicitis, especially in children and adolescents, and typically presents with RLQ pain and sometimes fever. However, the pain is typically less focal and less severe, and systemic symptoms may be milder. A key distinguishing factor is the absence of peritoneal signs with mesenteric adenitis, which are present in this case. Mesenteric adenitis often follows a viral illness. Answer choice E, nephrolithiasis, is incorrect. Kidney stones can cause sudden onset flank pain radiating to the groin, often with hematuria and restlessness due to colicky pain. This patient has localized RLQ tenderness with rebound and a positive psoas sign, indicating peritoneal irritation, and urinalysis is normal. These findings are more consistent with appendicitis than renal colic. Key learning point: acute appendicitis should be suspected in young patients with periumbilical pain that migrates to the right lower quadrant, especially when accompanied by anorexia, nausea, low-grade fever, and localized tenderness. Early recognition and prompt surgical management are essential to prevent complications such as perforation and abscess formation. Question 2, Pathology 56. A 26-year-old man is evaluated in the hospital 6 hours after undergoing open reduction and internal fixation for a closed right tibial shaft fracture sustained in a motorcycle accident. He reports escalating pain in the right leg that is deep, severe, and not relieved by intravenous morphine. He also notes numbness over the top of the foot. Vital signs are a temperature of 37.2 degrees Celsius or 99 degrees Fahrenheit, blood pressure 126/78, pulse 104 beats per minute, and respirations 18 per minute. On physical examination, the right leg is swollen and tense to palpation. Pain is significantly worsened by passive dorsiflexion of the foot. Sensation is decreased over the dorsum of the foot and active toe extension is weak. Pedal pulses are palpable and symmetric bilaterally. Which of the following is the most likely diagnosis? Is it A, acute compartment syndrome, B, deep vein thrombosis, C, fat embolism syndrome, D, necrotizing fasciitis, or E, postoperative wound infection? And the correct answer is A, acute compartment syndrome. Acute compartment syndrome, ACS, occurs when increased pressure within a closed fascial compartment impairs capillary perfusion, leading to tissue ischemia. It most commonly follows long bone fractures, particularly of the tibia, and may also result from crush injury, reperfusion injury, or tight bandaging. The earliest and most reliable signs are pain out of proportion to injury and pain with passive stretch of the involved muscles. Paresthesia, for example numbness, motor weakness, and a firm, tense compartment often follow. Pulselessness is a late finding, so the presence of normal pulses should not delay diagnosis. Compartment syndrome is a surgical emergency requiring emergent fasciotomy to prevent permanent nerve and muscle damage. Remember the 5 Ps: pain, pallor, paresthesia, paralysis, and pulselessness late. Answer choice B, deep vein thrombosis, is incorrect. Deep vein thrombosis, DVT, can cause unilateral leg swelling and pain, but does not cause severe pain with passive stretch or neurologic symptoms such as numbness or weakness. It also develops over days and is less likely in the immediate post-operative period, especially when anticoagulant prophylaxis is administered, though that information is not provided in the vignette. The tense, tender compartment and neurologic deficits in this case point to ACS. Answer choice C, fat embolism syndrome, is incorrect. Fat embolism occurs 24 to 72 hours after long bone fractures and classically presents with respiratory distress, neurologic abnormalities, and a petechial rash. This patient has no signs of respiratory distress, hypoxia, altered mental status, or systemic illness, and his symptoms are localized to the injured leg. Answer choice D, necrotizing fasciitis, is incorrect. Necrotizing fasciitis may present with severe pain and systemic signs, but patients are usually febrile, ill-appearing, and may have skin changes, such as boli, erythema, or crepitus. This patient is afebrile, normotensive, and has no skin findings. His pain is exacerbated by passive stretch and localized to a known injured compartment, hallmarks of ACS. Answer choice E, post-operative wound infection, is incorrect. Wound infections typically present with localized redness, warmth, tenderness, and sometimes purulent drainage or fever. This patient is afebrile and lacks signs of infection. Moreover, wound infections typically do not cause pain with passive stretch or focal neurologic symptoms, both of which are characteristic of compartment syndrome. Key learning point. Acute compartment syndrome is a limb-threatening emergency. The most important early signs are pain out of proportion to injury, pain with passive stretch, and tense swelling. Sensory and motor deficits are later signs. Pulses may be normal, as pulselessness is a late sign. Emergent fasciotomy is required to preserve limb function. Hey everyone, Chris here from MedPrep2Go, and I want to take a quick break to announce that our first course is now live. Comprehensive Endocrinology is a video series with Dr. Raj Dasgupta that features 9 hours of content in 8 modules. This course is useful for learning endocrinology for internal medicine, family medicine, USMLE Step 3, and COMLEX Level 3. And this content is exclusive to the video series and won't be available on any of our podcasts. Keeping with our philosophy of making medical education affordable and accessible, this course is available for just $10 a month or $20 for a year. So check it out now and start learning at medprep2go.com. And stay tuned for more courses coming later this year. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Question 3, Pathology 57. A 55-year-old woman presents to the emergency department with a 2-month history of fatigue, jaundice, and dark urine. Her medical history includes hypothyroidism, which is managed with levothyroxine. She denies alcohol use, recent travel, or new medications. Blood pressure is 115/70 and heart rate is 65 beats per minute. Physical examination reveals scleroicterus, hepatomegaly, and no ascites. Laboratory studies show total bilirubin of 6.2 mg per deciliter, normal range of 0.1 to 1.0, direct bilirubin of 4.8 mg per deciliter, aspartate aminotransferase of 120 units per liter, normal is less than 48 units per liter, alanine aminotransferase of 150 units per liter, normal is less than 55 units per liter, and alkaline phosphatase of 320 units per liter, normal range is 20 to 120 units per liter. Antimitochondrial antibody is positive. A liver biopsy reveals lymphocytic infiltration of bile ducts with granulomatous destruction and ductopenia. Which of the following is the most likely diagnosis? Is it A, alcoholic hepatitis, B, autoimmune hepatitis, C, hepatocellular carcinoma, D, primary biliary cholangitis, or E, primary sclerosing cholangitis? And the correct answer is D, primary biliary cholangitis. This patient's presentation of fatigue, jaundice, dark urine, hepatomegaly, elevated bilirubin/alkaline phosphatase, and liver biopsy showing lymphocytic infiltration with granulomatous bile duct destruction and ductopenia is characteristic of primary biliary cholangitis. Primary biliary cholangitis is a chronic autoimmune disease affecting small intrahepatic bile ducts, common in middle-aged women, most often diagnosed between 30 and 60 years of age, and is often associated with positive antimitochondrial antibodies. Ursodeoxycholic acid is the first-line treatment to slow disease progression. Answer choice A, alcoholic hepatitis, is incorrect. Alcoholic hepatitis is associated with heavy alcohol use, an elevated AST greater than ALT, typically 2-to-1 ratio, and Mallory bodies and steatosis on biopsy. Bile duct destruction and ductopenia are inconsistent with this diagnosis. Answer choice B, autoimmune hepatitis, is incorrect. Autoimmune hepatitis presents with elevated transaminases such as AST or ALT greater than 1,000 units per liter, positive anti-nuclear or anti-smooth muscle antibodies, and interface hepatitis on biopsy, not ductopenia or granulomatous changes. Answer choice C, hepatocellular carcinoma, is incorrect. Hepatocellular carcinoma presents with a liver mass, elevated alpha fetoprotein, and risk factors like cirrhosis or hepatitis B or C. Biopsy shows malignant hepatocytes, not bile duct pathology. Answer choice E, primary sclerosing cholangitis, is incorrect. Primary sclerosing cholangitis causes bile duct strictures and dilation on imaging, often associated with inflammatory bowel disease, primarily in men. Antimitochondrial antibodies are negative, and biopsy shows fibrous obliteration, not granulomatous destruction. Key learning point. Primary biliary cholangitis is an autoimmune disease of small bile ducts presenting with jaundice and elevated alkaline phosphatase. Positive antimitochondrial antibodies and granulomatous duct destruction on biopsy are key diagnostic points. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 1 questions at medprep2go.com. Happy studying!